My name is Tim Bickle. I'm going to be the moderator today. We have 40 minutes for the entire session. So that's going to be 7 minutes for each presenter and 5 minutes for the formal event. Hopefully I can show. The presenters will have 5 minutes to present their poster and then 2 minutes for questions. So that's 35 minutes there. So all we have left is we want to try to keep this as on time as possible can. If you have questions after the presenters have presented, but you can't get your question in those 2 minutes, feel free to contact any of the presenters. You can send them a message under attendees in event voting, or send them a message in the presenter's profile on the presenter's profile page. And we want to make sure everyone takes a moment to rate the posters under Vote People's Choice Poster Award tab in the event voting website. So I want to thank you all for attending. And here's our first speaker. And she will, all our speakers will introduce themselves and give you their poster type. And we're ready for our first poster.
Hello, how are you? My name is Veronica Brown with the University of Maryland School of Medicine, Department of Psychiatry. And my poster is on the perception of telepsychiatry during the COVID-19 pandemic. In response to the COVID-19 pandemic, telehealth care became the only safe measure to implement in clinical, healthcare, and educational settings. There is limited research for training of telepsychiatry and how to optimize patient encounters when utilizing video conferencing. There is no consistency in how telehealth was implemented in various curricula around the world. Content delivered usually included basic telehealth information, however, the depth of the curriculum varied upon the intervention given. Over 5 years, the Division of Addiction Research and Treatment at the University of Maryland School of Medicine has been delivering telepsychiatry statewide in conjunction with clinical services. A training program was created to educate addiction fellows in the use of telepsychiatry. This study examines fellows' perceptions of teleeducation, telepsychiatry implementation, and patient views of telehealth. As part of our continuous quality improvement effort, we assess fellows by conducting pre- and post-focus groups to evaluate their changes in attitudes towards telepsychiatry throughout their fellowship year. 3 psychiatry fellows were surveyed twice during their fellowship year. The first survey was conducted at the start in July and the second towards the end in June. Fellows stated that the use of medical centers' dedicated telehealth clinics helped overcome technical and environmental barriers that once would disrupt previous sessions in the past. Fellows also expressed that patients' level of comfort with telemedicine was correlated with age, income, access to telehealth care equipment, and technology literacy. All 3 fellows stated that they preferred the focus group method versus the quantitative yes or no survey method, as it allowed them the occupancy to talk more in depth about the nuances of providing telepsychiatry. Besides the overall satisfaction with telemedicine, telepsychiatry was deemed essential, and we will continue to evaluate the training program here at the University of Maryland in order to better assist future psychiatrists in treating the underserved rural and urban communities throughout Maryland. Thank you.
Yeah, that was shorter than 5 minutes, so you have a little bit more extra time for questions. Anybody have questions?
Hi, I have a question. Did your fellows have an opportunity, or did you look at whether they had prior telehealth training before their fellowship? You know, in their medical training?
This was first shared that the fellows did have telehealth education.
Okay.
I have a question. Can you hear me? See me? You had 3 fellows. Do you think that you'll do this again and try to get more participants?
Hopefully in the future, yes.
Anybody else virtually?
Great job.
Thank you. Thank you. Our second presenter, I'm not sure if they're virtual.
Yeah, I'm virtual. I'm here.
There we go.
Hi, everyone. My name is Megan Elliott, and I am from the Maryland Addiction Consultation Service as well, or MACS, from the University of Maryland School of Medicine. Today, I'll be sharing our poster, MACS Tele-Echo Clinics Promote Attitude Change Among Primary Care Prescribers Treating Substance Use Disorders, Preliminary Outcomes of a Qualitative Evaluation. So, MACS adopted the Tele-Echo model or extension for community healthcare outcomes to use a virtual, collaborative learning platform to disseminate specialty knowledge to community prescribers treating substance use disorders. We know from previous evaluations that ECHO models as a whole increase prescriber confidence in treating patients with substance use disorders, but the extent to which prescribers apply this knowledge learned and make changes in their daily practice as a result of the clinics is a bit more unclear. We use qualitative evaluations to dive deeper into the impact that these tele-echo clinics are having on our attendees' practices. So we contacted several attendees of various engagement levels in our clinics, and we had 9 attendees agree to participate in a brief, semi-structured interview. The MACS Tele-Echo Clinics consist of a participant-led, de-identified case discussion, followed by a didactic presentation by a MACS consultant who specializes in addiction medicine. 6 clinics were held monthly between February and June of 2021. So more details about our clinics can be accessed through the QR code at the bottom right of the poster. Our interview questions aim to identify practice change as a result of the MACS Tele-Echo clinics. We conducted these interviews via Zoom where they were recorded and transcribed. We used thematic analysis to identify core concepts and patterns from our transcripts. All of our participants were prescribers and most practiced family medicine and worked in an urban medical practice. We had a wide range of experience in the medical field from 5 years to 37 years. The mean number of sessions attended by our participants was 3 clinics, although we had some participants attend 1 and others attend all 6. So in our results section, you see major themes identified, some participant responses that led to the theme, and characterizing statements about the individual who gave the quote. The first theme is that participants experience increased confidence in managing patients. For example, a nurse practitioner stated that they used to be intimidated by substance use disorders, but after their work with MACS, they love it. The next theme is participants experience an attitude change in how they treat their patients with substance use disorders. A physician assistant stated that after listening to the case discussions, they thought, wow, this is really a disease like diabetes. The next theme is lessons from the clinics reinforce previous aspects of clinical care. For example, a doctor said I was doing it prior, but the clinics just reinforced it more. The next theme is dissemination of knowledge learned from the clinics. For example, a clinical nurse specialist stated that they take the lessons back to their practice and share it with their substance use counselor. Many providers that did not experience much or any impact on their practice reported barriers to practice change. For example, a doctor stated that leadership of the organization was not on board with treating addiction. In conclusion, some participants reported experiencing an attitude change in how they view their patients with substance use disorders and shared new perspectives with others. Additionally, some participants felt reassured that their current practices were validated by hearing others' methods. Those who did not experience much or any practice change often reported system-level barriers to implementing new concepts. These results support the previous findings that prescribers feel more confident in their clinical abilities after attending the clinics. These results also suggest that the MACS Tele-Echo clinics are effective in changing attitudes surrounding patients with substance use disorders in this sample of primary care prescribers. This is extremely important in the field of addiction medicine where stigma is a massive barrier to treatment and an ongoing issue. These results suggest that lessons taught in the MACS Tele-Echo clinics that help tackle system-level stigma, which could ultimately increase patient access to care and improve overall quality of care. So this preliminary evaluation calls for future research on the impact of tele-echo models on decreasing stigma within substance use treatment. And thank you guys. Any questions?
Any questions virtually?
need to cheer for her. She did a great job.
Thanks, everyone.
Next, presentation. Grace.
Hello, everyone. Can you guys hear and see me? Okay.
Yes, we're good.
My name is Grace Gustin. I'm the clinical social worker at Old Dominion University, and we're at the Penn Clinic, which is People in Need. So first and foremost, thank you so much for having me and hearing about the clinic that we have created. This clinic holds a very, very special place in my heart. We have helped many homeless individuals on a holistic level. I will be presenting on this poster titled Leveraging Telehealth, an Integrated Healthcare Model for Individuals Living in Homelessness. This poster outlines the development of a program that leveraged a nurse-led integrated care clinic using telehealth to connect with other providers. We realized early in the beginning of starting this clinic that this population needed more specific services like physical therapy and dental hygiene. Due to our ODU campus being 30 minutes away from the homeless clinic, we utilized telehealth, bringing them into the patient visits. The telehealth equipment that we used was Amwell with additional peripherals. The students that attended our clinic had many roles, but one of the most crucial roles was telepresenting. All of the students before coming into our clinic went through a telehealth education program facilitated by ODU. We have been able to successfully provide care to patients via telehealth, and which otherwise they would not have received services if it wasn't for this. Additional to physical therapy and dental hygiene coming in via telehealth, I as well have been able to attend those visits virtually when I wasn't able to attend in person. Telehealth has ultimately eliminated several barriers for this population, and it's helped them for physical health and mental health in many ways. Moving forward, this is a new clinic, and we're collecting data day by day, and on patient provider and student outcomes. We are most excited to report that despite the vulnerability of this population, they responded very well to the telehealth visits. For example, when I came in virtually for these visits, they would be very excited and say, "Hi, Miss Grace," and just be really excited to see me on the screen, which was really cool to see and watch. Additionally, our telehealth days are expanding. We're doing 1 day dental each month and 1 day physical therapy each month, not on the same day, on different days. So yeah, that's my poster.
How many patients have we seen?
It's kind of small. I think it's over 86 patients we've seen collectively, but that was from December. And so those data numbers have changed and they have grown immensely. And I kind of just ended up just talking, but this is Tina Gustin. This is the co-PI on the grant as well. And she has helped us immensely throughout this process in this clinic.
Where were the patients located for these services? Were they located in the clinic?
Yes. And to give you a background, this isn't just homeless living in a shelter. They're living in the woods in a tent mainly, or on the boardwalk.
Street homeless.
They're street homeless. They're not in the shelter. So they're very, very, very vulnerable. And we realize this has helped them in many ways.
One of the nice things about this clinic is the individuals that are receiving services are already coming into this. This isn't a shelter where they house individuals. It's a service where they come in for food, clothing, they're able to shower. So they are utilizing services at this agency. So when we came in with our integrated model, it took a while for them to build trust in us, but because they're coming there already for other things, it's easier really for us to provide healthcare services. And again, we realized this has been going on. Michelle's on as well. We're all three on the grant. We're in our second year now. So we incorporated the telehealth this past year, realizing that we really needed physical therapy. We needed dental hygiene. We're bringing in human services. We brought our undergraduate students in to serve as telepresenters. So we've really kind of expanded based upon the needs of the population, and telehealth has allowed us to do that.
Tina
Mhm.
and Grace, I just want to add, and I hope this isn't redundant, that, this is a very, not to be redundant, it is a unique population with special needs, and the telehealth has been very well received by them. And I think for the most part, they're pretty grateful for the care that they get. And so it's a powerful program, quite frankly.
Our physical therapy faculty and dental hygiene faculty and students have never physically been to this clinic. All of their care has been delivered remotely.
I have a question. Do you think that you could go device agnostic here, or do you think the Amwell platform was like part of your success? Like, could you have done this with Zoom?
It could be. The only problem with Zoom is we really have needed the peripherals. We have an oral camera. So if you could do some of your peripherals maybe with an iPhone in Zoom, it would work. The camera is but for this population, the one thing I will say is the screen needs to be very clear.
Mm-hmm.
It needs to be very clear, and the audio needs to be incredibly clear.
Yeah.
So it wouldn't work on the patient's own cell phone?
They don't have cell phones. Most of them don't. What they do have are track phones. I mean, that's the unique thing about this population. They're not FaceTiming. They're not on, they're just not social media users at all. So, or watch TV or go to movies. I mean, so the screen is really quite new for them, and they don't have phones. They had to come into the clinic to use our technology to have this type of care.
To follow up with the track phones, just because this is a kind of passion of mine, could the track phones support the technology?
Not that I'm aware of. The text-based, you could do text-based care. Not to get off on a tangent, but we've applied for a grant that we'll find out this summer. And in that grant, we're going to have a mobile van to go out to rural and underserved. And we're going to purchase an RPM device that has 4 levels of care to the individuals, realizing their technology and end use. And one of the versions will allow for just pictures and text-based. So we're trying to reach everyone where they're at and what they have.
And the majority.
You do.
Dr. Gustin, how many Amwell's platforms did you purchase with the grant? Is it just the one that you have at the clinic?
We purchased three different grants. And with that platform, we then purchased contracts for other providers or students.
So we can bring in, I believe, up to 20 different providers to provide telehealth services for us.
And related to the track phones and phones in general with this population, it's not a big need or hierarchy of need in their mind. They usually lose it or it gets stolen in the woods. And the majority of the time they come to Penn, this clinic, to use all forms of communication, whether that be calling the Medicaid office, calling their doctor's office, calling a family member. The majority of the time they're using the Penn's phone.
This isn't a unique population because we live in Virginia Beach. I mean, we didn't show you a map. So this is a Virginia Beach ministry. So the homeless in this region are here because it's a resort area. So they walk and bike to this clinic. They're all within walking and biking distance.
We're gonna move on. If you have more questions, we're gonna get to the end. Of then we still have some extra time. Feel free to ask.
Well done.
Thank you very much. Stern, are we virtual or is Kathy and Cicely virtual or in person?
We're virtual.
Okay.
Welcome. I'm Kathy Kramer, and my colleague is Cicely Sawyer, and we're very excited to share with you our story of Project ECHO. Project ECHO, impacting pediatric mental health, one hospital's journey. The American Academy of Pediatrics and the American Academy of Child and Adolescent Psychiatry, along with Children's Hospital Association, have declared a national emergency in mental health. As behavioral and mental health concerns continue to increase, there is a critical shortage of specialists to provide evidence-based treatment. The Project ECHO model, which is the extension for community health outcomes, was developed in 2003 by Dr. Sanjeev Arora at the University of New Mexico. Project ECHO incorporates guided practice principles to improve access to care by training community providers to independently treat patients within their own practices. At Cincinnati Children's, we applied this Project ECHO model to combat increases in mental health concerns. We designed multiple different cohorts around mental and behavioral health topics with the goal to increase the provider's knowledge and self-efficacy in evidence-based treatments, decrease variability in the treatments, and amplify local capacity. After an initial period of discovery and review, we offered our first mental health cohort in 2018. Project ECHO utilizes a unique hub and spoke model. The hub team is comprised of specialists along with operational support that reach out to community providers called spokes to engage in 8 sessions that are held bi-weekly for 75 minutes. The sessions involve didactic and case-based learning. This all teach, all learn model happens by providing opportunities for question and answer with the participants that allow for knowledge to be shared by all. The cohorts are offered at no charge and continuing education credits are given. I'm now going to turn it over to my colleague Cicely, and she's going to discuss our outcomes.
Thank you, Kathy. Standard evaluation measures collected across all cohorts are pre and post knowledge and self-efficacy assessments. Test results are scored and analyzed at the completion of each cohort to determine whether there was an improvement in participant aptitude. All knowledge assessments administered to date have seen an increase between pre and post test scores. Self-efficacy scores have either remained stable or increased as well. To ensure course content is and remains meaningful, we conduct post-cohort surveys in which participants are always asked if they would recommend this learning style to a colleague. 88.9% of those surveyed either agree or strongly agree with this statement. Impact is also measured through a provider's willingness to implement changes to their practice post-participation. To date, 82% of participants indicated having made some type of modification. A few common themes were increased comfort level in dosing and managing prescribed meds, consistent use of screening tools, increased referrals for cognitive behavioral therapy, and overall more confidence in addressing the concerns of their patients. A number of providers have even re-engaged in the process by either participating in cohorts related to the same topic or exploring a completely different subject. Project ECHO aims to equip providers with evidence-based practices that will allow them to better manage the care of young patients who are struggling with depression and anxiety at alarming rates. Taking into consideration the multiplier effect, potentially 18,000 lives have been touched because of a provider's participation thus far. In summation, I'd like to share a few provider testimonials that capture the essence of Project ECHO perfectly. One provider states, "Learning how to coordinate self-care, therapy, and medication provides much more rewarding outcomes for my patients and showed me that we can do far more together than what I can do in a single brief visit." While another says, "I truly love the concept behind the Mental Health ECHO series. I appreciate that the faculty completely understands that many of us were not trained to manage mental health, yet we are committed to helping our patients. The entire tone of the class is very positive and geared towards providing us tools to manage our patients. I can't say enough about these classes. I took a psychiatry class in 2017, offered on a different platform. It was all by phone or in person. I really like the ECHO format better because you can see the other participants and it makes for a much richer experience." Thank you for joining Kathy and myself on this exploration of Project ECHO here at Cincinnati Children's.
Virtually, we're in the room.
We love Cincinnati.
You can do however you want.
The embarrassing parents. We should need support. I'm totally kidding. Big fan. Hi, everybody. My name is Lily Staskis, and I think the name of it was tracked off, but it's disparities in telemedicine utilization by patient characters. And I represent Children's Medicine. So as we know, since the pandemic, telemedicine has become an integral part of the current and future state of care. Though it has enabled access to care for many, it has the potential to create gaps in access to virtual care as it relates to technological literacy, accessibility, and adult coverage. In our research, we aim to understand how access to telemedicine may be limited in certain patient populations. We were particularly interested in looking at telemedicine visits by modality, so comparing telephone versus video visits. And we were particularly interested in this because we've seen locally that high rates of telephone use are associated with difficulty accessing video visits. Prior literature has shown that certain patient populations are less likely to access video visits, such as those identifying as Black or African American, or the elderly population. And so our research adds this evidence by looking at encounter level data as well as patients located in Maryland. And we hypothesized that there would be substantial variation in telemedicine modality by 5 patient variables. So we looked at race, ethnicity, payer type, preferred language, and severity. So looking at our methods, we analyzed all telemedicine encounters at Johns Hopkins Medicine across calendar years 2020 and 2021. We used the telemedicine data dashboards, which display de-identified aggregate patient information as well as telemedicine encounter data. We then filtered these data further by those 5 characteristics I mentioned, race, ethnicity, et cetera. And again, we were looking for differences in telephone versus video use. Right, so then moving on to our results. So what did we find? So we looked at over 1 million patient encounters at Johns Hopkins Medicine across those 2 calendar years. We saw that across all patient populations, the average rate of telephone use was 17%, while the average rate of video use was 83%. But there were certain patient populations where we saw higher rates of telephone use versus video use. And so these populations included those who identified as Black or African American, those who identified as Hispanic, those who had preferred languages other than English, and those who were insured by public payers, so Medicare and Medicaid. We also saw differences in the zip code. So as you can see on the 2 zip code maps, anything that's red or orange shows high rates of telephone use versus video use. The map on the left shows that that little cluster in the middle, that's near Baltimore City, so the areas. The zip codes closer to the eastern and western parts of Baltimore City, as well as the southern parts of Maryland, had high rates of telephone use. And note that these are areas that also have other sociodemographic disparities as well. The map on the right shows the same data, but is filtered by patients 65 years or older. So you can see that this difference is even more dramatic. All right, so in conclusion, we see that disparities exist based on telemedicine modality and according to those 5 patient characteristics with race, ethnicity, payer type, preferred language, and zip code. Individual and zip code level characteristics are associated with patients' access to video visits. And for our research, for next steps, we're trying to do some more sophisticated statistical analysis to see which patient variables are uniquely associated with telemedicine modality. And finally, future research is needed to determine if the telemedicine modality is associated with or if it impacts patient healthcare outcomes.
Any questions?
Yeah, in the insurance type, It's a little hard to see, but it's Medicaid, Medicare, other, is it other payer?
Yes.
And then is that private under?
Private and self.
So what was in other payer? What pensions were in there?
That's a great question. It's commercial.
Okay. So were you surprised to see that commercial had more phone visits than, say, Medicaid and Medicare?
I mean, it is surprising, but I think more so what's more important to us is looking at the end of the counter. So there will be 5,000 patients who had other payer versus the, 600,000 that had public payer or almost 700,000 had private payer. So we really checked on that since it's such a.
I'm sorry, commercial is different than private? Is that what you're asking? Other payer is different than private? Is that what the clarification
Yeah,
is?
that's what I was.
Yeah, I didn't understand the
Yeah,
clarification.
I think one is employer and one is commercial. We can get
It
back
may
to
also
that.
be somebody just doesn't know what they have and they just put other.
Right.
Yeah, but thanks for pointing out that number up. We couldn't see that.
It's
Yeah.
small.
Just
It's all at the right
it's a tiny
time.
difference.
Right.
I mean, to me, it's so interesting when Jonathan in the room, especially looking at the rural need and the urban need, and both of them just lighting up, right? Really seeing the butterfly effect for Baltimore City, and then our urban,
Right.
I mean, our rural areas.
Yeah, and then this is only like part of Maryland. When
Yeah.
you zoom out and look at the entire state of Maryland, you see even more.
Yeah, Eastern Shore.
Yeah, exactly.
Eastern Maryland.
Yeah, that was going to be my question, just looking at the map, I sort of know the area, but to overlay rural, urban, to see a difference that way with the zip codes.
Yeah, so we're actually, for our research, we're trying to find some sort of sociodemographic factors, whether it's access to internet or I think there are some indexes that show like sociodemographic disparities. So we're trying to overlay those maps and do some geocoding with our maps of telemedicine utilization.
And I think it would be interesting to look at density too.
Yeah.
To look at, here it is in miles, right, or how much space it covers, and here's the amount of patients in those areas.
Right. Like this makes sense as if you know where Baltimore is and somebody doesn't know.
Yeah, you could even do a HRSA map to look at areas that are underrepresented by providers and different providers.
And our HRSA map in Maryland is horrible.
Yeah, I mean, that would be a really interesting, I don't know, we have areas in Virginia that are underrepresented but not considered rural and vice versa. So, anyway.
Great job.
We have just a few more minutes. Does anybody have any other questions for any of the speakers? Any of the presenters? If not, I'll wrap it up a little bit here. I want to thank everyone for attending this poster presentation session. And because we have so many poster presentations that are being held simultaneously, please go online and you can look at all the posters. And each poster presenter has recorded a 1-minute elevator speech talk to go with the poster. So feel free to look at those, and please go and vote for your the People's Choice Poster Award virtual via the virtual platform for the agenda app. So there's no other questions or comments. To go comments or thank you all very much.